All right, types of strokes. You have hemorrhagic stroke. Some of the common signs and symptoms: headache, nausea, vomiting, weakness to one side of the body, decreased level of consciousness. Okay. Your hemorrhagic stroke with bleeding in the subdural space. This is subarachnoid hemorrhage. Okay. Worst headache of their life. That is your hallmark sign and symptom. Intolerance to light, vomiting, decreased level of consciousness. Your role is going to be to provide supportive care to the patient by managing any immediate life threats and by collecting the most accurate information possible to report to your emergency department or wherever you're taking them. Your purpose in collecting the information isn't to distinguish between the types of strokes, but to report it accurately to the emergency department and staff. Okay? Stroke patient will often suffer paralysis affecting the face and extremities on one side of the body. Most commonly, it involves areas of the brain that control speech, sensation, muscle function. All right? Somebody know what a TIA is? Transient ischemic attack. Okay? It has the same signs and symptoms of a stroke, but the symptoms usually disappear within 1 hour. All right? The emergency care is going to be the same. And even if you get to their house and you tell them, or they tell you, I've had a TIA before, that's what's going on, blah, 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 blah. TIA is like a warning sign of a big stroke to come, okay? They need to be taken and being evaluated, all right? So if you go to a stroke call and they start miraculously getting better on the way to the hospital, you can classify that as what? A TIA, okay? And that is something important that you need to relay to the emergency department staff, okay? Signs and symptoms of stroke are associated with a specific area of the brain that has been affected by the disruption of blood flow. Most commonly, it involves the areas that control speech, sensory, and muscle function. The onset of the signs and symptoms is usually sudden. However, some symptoms can be gradual and might continue to progress as the cells become more ischemic or more infarcted. All right. Strokes are also categorized as anterior or posterior circulation. This only describes the area of the brain affected, but also the typical signs and symptoms expected. Okay. For anterior circulation, you should have weakness, clumsiness, heaviness, or complete paralysis of the hand, arm, leg, or face on one side of the body. Numbness, tingling, loss of sensation. A language disturbance, all right? The patient knows exactly what they want to say. However, they have trouble saying it because they can't form the right responses in their brain or pick the correct word. All right, receptive aphasia. The person has difficulty understanding what you are asking or telling them, okay? They might respond fluently with words that don't match what was asked or told. Then you have global aphasia, which is the most severe but most common after a stroke. The patient can't understand or speak to you. You have vision disturbances, total or partial loss of vision in one eye. The patient might also describe their vision disturbance as a dropped curtain, a fog, or a grayout or blackout. All right, you have problems with eye gaze, okay? The eyes can have a conjugate, which means both sides together or both eyes together. Gaze on the side of the brain that the clot is on, okay? So if you walk in and you're talking to this patient and they're looking to the right side, if their eyes are looking, not necessarily their head, but their eyes are pointed to the right side, that's called a conjugate gaze, okay? Or the left side. It can be either side. And you can have a stroke on either the left or the right side. I've been asked that question before, and I'm not really sure why, but I figured I would clarify that.
Wait, say that again.
You can have a stroke on the left or the right side.
Like Oh, at the same time?
Yeah. Or left, or right, or both. Common signs and symptoms of a posterior circulation stroke: paralysis, motor deficits, weakness, clumsiness, pretty much the same thing. All right, numbness, tingling, language disturbances. Aphasia usually does not occur. All right, means they can usually talk. However, they can have dysarthria, which is slurred speech or difficult understanding speech. Vision disturbances. They might complain of double vision or bouncing or moving visual objects. You might also see that the eyes aren't looking in the same direction. So if one eye's going one way and the others are going the other, that's a bad sign.
That lady we had that was saying okay the whole time,
Mm-hmm.
she had a stroke, and her, the paramedic said it wasn't super common when people were different sizes.
Mm-hmm.
Is that not super common?
It just depends. Depends on the person, where the stroke was, but the pupils can tell you a lot.
I thought it was super cool. She said right now, like going into 10, she said.
Yeah.
Actually,
And sometimes they'll go back to normal, sometimes they won't. Like I said, it all depends on where, and the brain is very, very, very complex. According to the AHA, most TIAs last less than 5 minutes, with the average being 1 minute. The signs and symptoms of a TIA typically only last a few minutes, and most resolve within 60 minutes. However, many do so before 30 minutes. When the temporary blockage of the cerebral artery occurs, the brain cells distal to that vessel receive a significantly reduced amount of blood or no perfusion. This creates cellular ischemia, and the brain cells become electrically silent, producing the typical signs and symptoms of a stroke. And there's a little statistic up here: 10 to 20% risk of a stroke in the subsequent 90 days. Half of these occur within 24 to 48 hours. So a TIA is a warning sign, okay? And they need to be evaluated. And sometimes, if the TIA resolves, or they have like little things that are still happening when they get to the ER, they will actually admit them for 48 hours, just to keep an eye on them, okay? Because, if they're going to have a stroke, you'd rather have it in the hospital where they can, go ahead and give you what you need. That's less chance of any kind of deficits you would have. All right, a cryptogenic stroke is defined as one that can't be conclusively attributed to an embolism originating from the heart, a thrombus in the artery, or a small artery disease, despite extensive medical diagnostic testing. A cardiac embolism secondary to atrial fibrillation is thought to be a common cause. Other possible causes include a deficit between the walls of the aorta, thrombophilia, which is an abnormal tendency to form clots, all right? You have these people that are like hemophiliacs that can't, their blood won't clot. Well, just like a hemophiliac, you have the opposite end of that spectrum. You have people that their blood is too thick. And I'm not real sure right offhand, if somebody wants to Google it, what that's called. A non-bacterial infection to the inner lining of the heart, which is endocarditis, and a cerebral vascular disease that is subclinical or not yet producing any signs. All right. As you arrive, you want to scan the scene to try to determine whether the neurologic deficit is due to trauma or any other. Hypocoagulability.
Polycythemia is where your body makes too many red blood cells, and it makes it different.
Okay.
It says thrombophilia is an abnormality of blood coagulation that increases the risk of heart failure.
So apparently there's a lot of different sub-causes of that. Okay. you want to look around to determine if it's medical or trauma. Look for any signs that would make you suspect that the patient's head or spine has been injured. Scan for alcohol, drugs, paraphernalia, and prescription or illegal drugs. Specifically look for evidence of methamphetamines, cocaine, and other stimulants because they are related to non-traumatic brain injury in young adults. The patient is found. Notice how they're dressed. Many strokes occur at night and the patient awakens with the neurologic deficit. Okay? So one of the things that we need to ask these people is, when were you last seen normal? All right? Especially if they have family and friends around. Okay? When were they last seen normal? Did they go to bed normal and wake up like this? All right? Or were they just sitting here watching their stories and all of a sudden started having some slurred speech, paralysis on the left side, weakness on the left side, that sort of thing, okay? So if you went on a call and the patient woke up that morning with the neurologic deficit, how are we going to determine when they were last seen normal? Okay. What are we going to ask them? Were they normal before they went to bed? Okay. So, how many hours of sleep do y'all get every night? 6. Okay. 6 is the cutoff for most clot busting drugs. So that's very, very important if we can pinpoint what time. If they went to sleep at midnight and they got up at 4 this morning, are they going to be a candidate? Probably so, okay? That's something really important that we need to think about, okay? Any patient presenting with a sudden weakness of the face, hand, arm, leg, trouble speaking or stuttering, difficulty seeing in one or both eyes, problem walking or loss of balance or coordination, confusion, dizziness, sudden onset of severe headache should be suspected of suffering a stroke. If the patient is unresponsive, perform a physical exam, obtain vital signs before obtaining the history. If the patient is responsive, take the history before performing the physical exam. Physical exam is a rapid head-to-toe assessment. Any patient with a loss of motor or sensory function, difficult speaking, altered mental status, may be suffering from a head injury. Carefully inspect and palpate the head to determine if there is any evidence of trauma. And as always, assess the airway. Suction is needed. Position the patient. Use an airway adjunct if you need to. Assess for adequate or inadequate breathing and abnormal breathing patterns. And if our oxygen is less than 94, what are we going to do? Put them on some oxygen. You want to inspect the face for drooped appearance on one side by instructing the patient to look at you and smile or to show their teeth. You want to listen for garbled speech sounds, slurring when the patient speaks, okay? If they have a family member there and maybe they've had a stroke before, you can ask the family member, is this how they normally talk, okay? You can assess their speech capabilities by asking them to repeat. You can't teach an old dog new tricks. An abnormal finding would be if the patient said the wrong words, slurred the words, could not say the phrase at all, uttered a completely unrelated phrase, or didn't understand your directions. Okay? And it doesn't have to be you can't teach an old dog new tricks. It could be 30 days has September, April, June, and November. Okay? Whatever you get them to say doesn't matter. Okay? Everybody understand that? If you find the patient walking, note their movement and the manner they are walking. An abnormality such as an unsteadiness can indicate a neurologic deficit. When assessing the extremities, you may find a reduction in sensory and motor function on one side of the body. This is why we do things in pairs. All right, especially your pulse, motor, sensory. All right. If you check one side with one hand and then check the other side, are you going to be able to tell if there's a difference? That's why we do it at the same time. Hey, squeeze my fingers. Can you feel me touch you? Just like we do with the long spine board, okay? Or any of that stuff. All right. So, some of the things we need to talk about is the Cincinnati Pre-Hospital Scale, all right? It's in your book. This is what we use, especially around here, for stroke evaluation, okay? It tests for facial droop by having the patient show their teeth or make a smile, arm drift by having the patient close their eyes, hold both arms straight out in front of them for 10 seconds, and abnormal speech pattern, okay? There's some other stroke scales and stuff in here, but this is the one that's most commonly used. During your history, look for medical alert tags, collect the patient's prescription and non-prescription medicine, and don't forget to look in the refrigerator for a vial of insulin used to treat diabetes. All right, remember that diabetics may be hypoglycemic, and patients who are hypoglycemic may show signs and symptoms similar to those of a stroke patient, especially if the patient is elderly. Okay? All right, blood restored to the area of the brain tissue that was previously ischemic from low blood flow or occlusion of the vessel is called reperfusion. The oxygen in the blood flowing to the reperfused brain tissue increases the production of free radicals, just like it does in the heart, you guys. It directly damages brain cell membranes and other cellular components and results in brain cell death. A higher oxygen level in the blood results in a greater production of these damaging free radicals and causes greater brain cell and tissue death. It is extremely important to limit oxygen therapy in the stroke patient. It is recommended that oxygen be provided to stroke patients with an SpO2 less than 94. All right. So this is what a normal and an abnormal facial droop. When you ask them to smile, does both sides come up normally? Okay. The lady on the other side with the eyes closed, her left side comes up, her right side's not really moving a whole lot, right? Remember, it's always the patient's side. All right, arm drift. A stroke patient will often display arm drift or pronator drift. That is, one arm will remain extended when held outward with the eyes closed, but the other arm will drift or drop downward and pronate, okay? When you close your eyes, that's the signal to the brain, okay? If your brain does not see that arm, it does not know that it's there after you've had a stroke, if it affects that side, okay? It could be the right side or the left side. They have to close their eyes, all right? Does everybody understand that? All right, abnormal speech, have the patient say whatever you want them to, okay? And just look to see if they can repeat it back to you like they're supposed to. All right, that's Los Angeles. Stroke and TIA are conditions that may result from non-traumatic brain injury. Loss of speech, sensory, or motor functions and altered mental status are among the possible signs and symptoms, and facial asymmetry is a common sign. They can have all of these other things. A change in personality. Where's your personality at in your brain? It is the front. It is the front side. Okay? Unequal pupil size. Drooping eyelids and mouth on one side of the face. The arm drift. Loss of bowel or bladder control. They can even have seizures. Okay? Nausea, vomiting. All right, airway compromise in a stroke patient is common. It may be necessary to insert an OPA or an NPA. Maintain their airway, suction is needed. Assist ventilations is needed. You want to maintain your adequate oxygenation and position the patient, okay? If the patient can't protect their airway because of a reduction in their mental status, place them on the what? Which side? Left side. Why do you put them on the left side, not the right side? No. It's easier access when you get back in the ambulance. Most of the ambulances that you will come in contact with, unless it's a box truck, I don't really know about the Sprinter units. I think they're free on both sides. But most of the time, where this guy's standing back here, that stretcher goes all the way up against that side of the truck, okay? So, especially in the vans, the old vans. In a box truck, you can put them on either side, it really doesn't matter. But, you'll have access from this front side and this back side. Most of the smaller trucks, you're only gonna have access from that front side.
The new passer, they're 2021s, and they can
Do it that way. Yeah.
Do y'all have the box trucks?
Yes. If the patient wants to be placed in a semi-Fowler position, don't elevate the head and chest more than 30 degrees. Okay? Why would we not want to elevate their head and chest more than 30 degrees? Because of what? You're right.
There's an artery there. That's what I'm saying.
Because it's above your belly?
What did you say? About intracranial pressure. Okay. The higher up you sit, the more intracranial pressure you're gonna have. Okay. All right, check the blood glucose level if your protocol permits. Yours will permit. If the glucose reading is less than, this says 70, most services around here use 60, okay? Suspect a low blood glucose is the possible cause of signs and symptoms, especially if the patient is elderly, okay? Because if they have a paralyzed extremity, it is vital to protect that extremity from any injury, okay? A lot of times, I will go ahead, if they're not moving that part, I will secure it with a strap, okay? Because that's really the last thing you want to do is Granny's having the worst day of her life and you don't secure that arm and it flops down when you're coming out 85 doors, because she's always in the back bedroom somewhere, and you get out to the truck and there's a pool of blood trickling behind you because you have, like, pulled all the skin off of her elbow and arm getting through the doorways, okay? You want to transport any patient with a suspected stroke to a medical facility capable of immediate imaging and intervention. That would not be East Carroll Band-Aid Station.
So in all cases, you bring Dr. Miller.
More than likely, yeah. Alright. Headache may be a condition in itself, or it can be a symptom of another condition. Vascular headaches occur because of the dilation or distension of vessels or inflammation within the cranium. Migraine headaches are thought to be caused by spasms of the vessels, followed by vasodilation and a change in the chemicals that transmit nervous impulses in the brain. That's the wrong number because nobody calls that phone. Migraines are often described as throbbing and can be generalized or localized to one side of the head. The patient also commonly experiences sensitivity to light, known as photosensitivity or photophobia. Nausea, vomiting, and sweating. A vascular headache can also be caused by high blood pressure, which is what I've had for the last 2.5 days. Typically reaching a diastolic pressure of 120 for a headache to occur. Cluster headaches are headaches that occur repetitively in clusters. They are similar to migraines because they are believed to have a vascular origin. Tension headaches are thought to be caused by contraction of the muscles of the neck and scalp. The pain is usually described as tight or vice-like. This is the most common type of recurring headache found in children, adolescents, and adults. I get these like a lot during the summer because like I wear glasses a lot. Sometimes I wear my contacts, but like I notice during the summer, like if I sweat, my glasses fall down like on the tip of my nose. So usually I will pull my ears back because I'm one of that like 5% of people that can pull their ears back. I will sit like that all day and my neck like right back through here and like up around. I can tell when I've been doing it. Do you do that? You don't have that problem? Hang on. I can't do it with everybody fucking looking at me. Jesus Christ. I can like wiggle my ears.
Oh.
That's what I'm talking about. And I probably can't do it right now because I've had these glasses on for like forever. Like that muscle probably like staying there right now. Anyway, organic headaches are also called traction or inflammatory headaches. These aren't simply headache conditions, but rather a symptom of another condition. It may be the result of tumors, infection, stroke, or inflammatory disorders within the cranium, such as a hemorrhage or meningitis. During the scene size up, look for clues that a headache might be associated with a toxic exposure. Assess the airway, ventilation, oxygenation. Apply oxygen based on the SpO2 and patient presentation. Pain often triggers the sympathetic nervous system and causes tachycardia and pale, cool, clammy skin. Perform a history and secondary assessment. Alright, looking for any underlying cause of the headache. And check your blood glucose level. Alright, you want to suspect a serious underlying condition with any of the following. This is the first experience of this type of headache with an abrupt onset. Worsening pain with cough, sneezing, or bending over. Fever or stiff neck. Fever or stiff neck makes you think of what? Meningitis. I'm going to learn y'all something after all. Change in the quality of a chronic headache. Okay? I know that my headaches are from not taking my blood pressure medicine. Because once I start taking it again, I'll be A-okay. So, headaches. We're going to maintain or establish and maintain an open airway and be prepared to suction. Assess and maintain adequate ventilation. Administer oxygen for an SpO2 of less than 94. Put them in a position of comfort. Be prepared for seizures and transport. Alright, because Mr. Hewlett slurred speech, both EMTs are immediately aware of the potential for airway compromise. Fred carefully assesses the airway and breathing as Reese asks Miss Hewitt what happened. Mr. Mr. Somebody is alert and appears frustrated at his difficulty in making himself understood. Fred assures him that they will quickly do what they need to do and then get him to the hospital for further assessment and care. Fred's stroke scale assessment confirms facial droop, difficulty speaking, and reveals a slight weakness of Mr. So-and-so's left hand. Mr. Whoever is able to maintain a sitting position, so the EMTs position him in a semi-Fowler's position on the stretcher. Meanwhile, gotta sneeze. Reese was able to obtain information from wifey, including the time of onset, signs and symptoms, which they will know is important in determining ongoing treatment in the hospital. Alright, any questions about strokes, headaches?
With the stroke, you know, if you have a heart attack, one part of the another one, is it the same thing as stroke?
Yes and no. It all really depends on your medical history. And if you've had one before, that it's going to be really hard to determine, especially if you have deficits from